One thing I have to clarify is that, yes, there are patients who are ineligible for intensive chemotherapy, but that is not the same as ineligible for transplant. So I think there needs to be a differentiation. When someone comes in with leukemia and is very sick and does not feel well, has a poor performance status, they may be considered ineligible because of how bad they look. And there's always a lot of physician judgment that goes into what part of this is leukemia and should I still give intensive chemotherapy versus not. That is a clinical judgment, and we have developed that over time. But it's very important to assess the patient after they're in remission, because you may find that their performance status greatly improves and now they can be transplanted even if they got lower intensity therapy first. So that has to be, I just want to clarify then, put it aside, that we need to consider transplantation when it's necessary. Now, in terms of choosing the right frontline therapy, if they're not intensive eligible, we have HMA and venetoclax as an option, which is generally the backbone of lower intensity therapy. Then on top of it, we also have HMA if patients have an IDH1 inhibitor in the frontline setting. HMA plus ivosidenib has an approval in this setting, which is targeted, well-tolerated regimen. Again, can be continued or moved to transplant depending on how the patients do. For patients who have a FLT3 mutation, there are currently clinical trials ongoing with triplets of HMA, venetoclax, and gilteritinib. So that would be a way of improving survival, adding targeted therapies to the backbone of HMA and venetoclax. And the one thing about lower intensive therapies, we have learned that the ELN risk doesn't quite is not the same for patients treated with HMA venetoclax therapies. And the two groups that seem to perform a little bit inferior for HMA ven is people who have FLT3 mutations, RAS mutations, and TP53 mutations. So if they don't have this, they do very well with HMA venetoclax backbone. They get that. Or if they have an IDH1, you have HMA and ivosidenib. If they have a RAS mutation, again, right now we don't have any RAS targeted therapies. So right now our best strategy is, HMA ven. Possibly there is another regimen, cladribine, low-dose and venetoclax, that could be used in these sort of RAS mutated mutations. So it's either one of those two. And then for TP53 mutations, we don't think HMA venetoclax improves survival in the long term. I still use it for inducing remissions and then trying to get them into transplant. But if they don't go to transplant, we don't want to give too much venetoclax to these people. They could be continued on single agent HMA, for example, for as long as it lasts. So I think picking the right regimens that we described and then trying to get them into transplant would be the best way to either cure or improve survival for these patients.